Oh, that's fun. Okay, so just for Jay, this is Synapses Epilepsy. Um, there's a lot of information. Let me find there you go. This is the syllabus like part of it. It's a lot. Um, I'm not going to do all of it in like great depth. I'm just going to kind of whistle stop through it. You don't actually have to know anything in masses of depth. Just general knowledge is good. And then on the side, I've kind of color coded what we're doing. You know, like syllabus, clinical, experimental. And I've got this weird little blue dot as well for stuff that isn't on your syllabus, but is is in like the extra parts. So we shall start. I have Slido slides. If you want to do the questions, then you're very welcome. But if it's just like since it's just you, you could just tell me, and we don't have to like you won't have to like QR code or anything.
Okay.
Um, this is the stuff we're going to cover in normal words. So just what are synapses, what are neurotransmitters, a bunch of the main neurotransmitters, and then a bit on epilepsy as well. So what is a synapse? It's the joining between two cells, and it's how we pass electrical signals between our two cells. The cells can be two nerves, or it can be like a nerve and something else. So usually like a muscle or something like that. Um, there are two types of synapses. You've got chemical, and electrical. Electrical you don't really need to know about, but it's basically when there's two cells that are very close to each other. You've got the cell membranes, and you have a pore going directly from one to the other. So all of the ions can travel both ways. And it's basically for kind of synchrony of networks rather than taking a message from one place to another. Chemical synapses are the ones that use the neurotransmitters, so they only go from one direction to the other. You've got a presynaptic and a postsynaptic, and depending on whether the ions that the neurotransmitter allows into the postsynaptic cell are positive or negative, it will hyperpolarize, depolarize the postsynaptic cell, making it more likely to fire. That's an excitatory um, potential, or it will hyperpolarize it, making it less likely to fire. Then that's an inhibitory one. So the basic pattern is your neurotransmitter is released, it activates a channel which opens, and then either you get positive ions coming in or positive ions going out and negative ones coming in. That leads to either depolarization and excitatory potentials or hyperpolarization and inhibitory potentials. All of those potentials at the end plate add up to determine how likely it is that an actual potential is going to fire. And that can be like we call that summation. That can either be in space, so many end plate potentials, many presynaptic neurons acting on one postsynaptic neuron at once, i.e., coming from lots of different places, or it can be in time, so one presynaptic neuron firing repeatedly, like activating a postsynaptic one repeatedly in time, and then all of that adds up. It's good to note that the end plate potentials can be excitatory and inhibitory at the same time, as in you can get different ones, and then it's the balance of those that determines whether the action potential will fire. And that is your summation. Bit of experimental. This is kind of a classic, very classic discovery of neurotransmitters. Otto Loewi took two frog hearts, both denervated, but both still, well, not separated, but both still beating. Put them in a generic fluid, and then in the first heart, he stimulated the vagus nerve, which can you see my pointer by the way?
Yeah.
Okay. So this is the heart rate of the heart. You stimulate the vagus nerve, it decreases it and it becomes slower. And then when you take the stimulation away, it becomes faster again. And obviously, heart two, when he does that, nothing happens because it's not being stimulated anyway. But when he takes the fluid that heart one has been in and adds it to heart two, he finds the same thing happens. And that tells him that heart one is releasing something into the fluid that is causing this to happen. So there must be a chemical in there. That is the discovery of ACH. So the very basics of neurotransmitters, chemical messages between nerve cells, you know this. There are two types, so they can be fast acting. Those are the ligand gated channels, that's the ionotropic receptors, where the neurotransmitter binds, the channel opens, the ions come straight in. It's a sort of very short process. And the main ones that do that are glutamate and GABA. Or you can have slow acting ones, which are GPCR, like G protein coupled, called the metabotropic. And the neurotransmitter binds to the receptor, which then via second messenger cascade opens a pore. So it takes a little bit longer just because there's another step. And that's mostly the other neurotransmitters will cover. So ACH, serotonin, noradrenaline, dopamine act like that. Um, Synaptic transmission, it's just a very basic diagram, but easily copyable into an essay. I do this in my notes app, so it's doable. You start with a precursor that can come from within the cell, or it can come from, the diet and is being brought into the cell. The precursor is synthesized into a neurotransmitter, which is stored in the presynaptic cell. It then is caused to be released, usually by electrical signals coming into the presynaptic cell. It's released from its vesicle, which is being stored into the synaptic cleft. It activates its receptors, which are the red ones down here. And then when it's done that, it is reuptaken by this green guy back into the presynaptic cell for metabolism, so to be broken down, sometimes recycled. And that's to stop there being too much activation in the synaptic cleft. If we just leave the neurotransmitter there, it will just keep activating and everything will go a bit wrong. And then in some cells, you also have autoreceptor activation, which is when you have a receptor for the neurotransmitter that's being released on the presynaptic cell. So that can tell how much a neurotransmitter is in the synaptic cleft and acts as a bit of a negative feedback loop on the presynaptic cell, telling it to, we've got enough now, you can stop, basically, acts as a bit of a break. I am someone who likes having all of my information in one place. So I've got several of these sort of flashcard-esque slides that look quite scary and there's lots of information. If you don't like that, you could ignore them. I'm going to cover the important bits kind of broken down, but I find things like this nicer to revise from. So that's just me. But we start with glutamate. It's the main excitatory transporter. It's used in sort of 90% of the functions in the brain. And the main kind of things you need to know are that it can be made from the TCA cycle and from glutamine, and also that it is recycled. When it's metabolized, it can be like remade because we can't get it from the diet. So it has to come from within the body. There are 4 types of receptors, which are AMPA, NTMA, kainate, and the metabotropic glutamate receptors. We're not going to cover kainate. They're basically the same as AMPA, but we won't cover them. There we go.
So this one is NMDA.
Yeah, fab. And it's going to say no one participated. I love when it does that. So that the reason that the fact that it's sodium and calcium will become important in a bit. We'll cover that. So these are our main 3 types that you need to know about. As I say, kainate's very similar to AMPA, but just like less important, basically. So AMPA and NMDA are our ionotropic fast-acting receptors. NMDA takes a little bit longer than AMPA. AMPA is the really quick one. Again, we'll come back to this. But they both work by depolarizing the cell. They make it more likely that it's going to fire, so they're excitatory. And then the metabotropic receptors, they work kind of in a modulatory way because they're sort of slower acting, GQ coupled. There's not masses you need to know about that basically, other than they're metabotropic. Glutamate is really, really important in loads of stuff. So this is a very brief summary of the importance of glutamate, but little bits of clinical relevance that you can stick in. It is important in epilepsy. We'll cover this in a little bit. We know this because some of the epilepsy drugs we use inhibit glutamate, and that decreases the excitation, stops you being epileptic. Excitotoxicity is something that's on your extra bits. Basically, when the brain is damaged by ischemia or lack of oxygen, the damage to the cells makes more glutamate be released. That increases the activation on the NMDA receptors. That lets loads and loads of calcium into the cells, and which obviously that can kill the cells. And that's kind of the mechanism of how things like stroke, how that the ischemia and the pathology leads to the loss of function. It's like cell death mediated by this glutamate pathway. And ketamine is something that everybody loves to hear about because it's super big in experiments at the minute. It's an NMDA antagonist and it's used in all sorts of stuff. Loads of research ongoing. I haven't put any papers in here because I'm sure you're inundated with them already. But if you're interested, yeah, look into it. It's really cool. LTP and LTD, covering it very briefly because there's so much to say and it's so complex. But at its basic level, it's usually glutamate mediated, and it's the mechanism by which we strengthen our synapses and we like learn and retain information in those synapses. So glutamate's released. It activates the AMPA receptors, which just take it up, ions go in, cell depolarizes, this is fine. The NMDA receptors, it takes them a little bit longer because they are blocked with this molecule of magnesium that's positively charged. So obviously it's attracted to the negative charge on the membrane potential, which means that it takes a little while for the activation of the AMPA receptors to let enough sodium into the cell for the cell to depolarize to a positive enough level that the magnesium dissociates from the NMDA receptor, and then you can get the sodium and the calcium coming in. Once the calcium's in the cell, it activates this thing called CAMK2, calcium calmodulin kinase 2, and that through a whole complex signaling pathway acts to upregulate the expression of AMPA receptors at the synapse. So that's like adding more in to the membrane, and it's also strengthening the ones you have. And this is basically is what we call Hebbian theory from Mr. Hebb in 1949, which the basic principle of it is that the more we use a synapse, the more it becomes strengthened. And by strengthened, we mean like how efficient it is. Um, so that's the process of LTP. LTD is works in a similar way, except the opposite. The less you use the synapse, the less the less strong it becomes, and the less we can utilize the information from it. The very classic experiments for LTP and LTD, which I'm sure you've seen. The first discovery of LTP was by Lomo in 1966, and he took some cells and activated them using tetanus, which are what these arrows along here are, and measured the end plate potential, the positive end plate potential. And he found that when he did this, it not only did it increase when the cell activated, but it stayed that way for quite a long time. So there's like a prolonged a prolonged increase in efficiency of the synapse. That was the basic discovery of long-term potentiation. And then Jones et al. Is just an example. There's been many experiments like this, whereby if you chronically stimulate the membrane at a very low frequency, it it downregulates the expression of AMPA in a sort of similar way, and it decreases the end plate potential. So if we don't use the synapse at all, it degenerates. You get neural pruning. If we chronically stimulate it at a very low level, it degenerates as well. It's basically a lack of that high frequency input that is stopping the synapse being kept up. That's how long-term depression works in a very, very simple way. And this is my excuse to add in my favorite study of all time, which I put in everything. I find it much easier to learn one study that can be applied to loads of things than loads of studies for specific things. This is one of my favorites because it can be used for all sorts of stuff, like sleep, glutamate, LTP, memory, all sorts. So Vlad from Hartford did this study in 2008 where he took a bunch of rats. Half of them had a 6 hour period of being asleep, and half had a 6 hour period of being awake. And then he homogenized the brains and looked at the expression of AMPA receptors on their postsynaptic membranes. So that's GluR1 is a subunit that is in the AMPA receptors. So that's kind of a proxy for that measure. And he found that the rats that had been awake for 6 hours, they had much higher levels of AMPA expression on their postsynaptic membrane than the ones who'd been asleep. So basically, they've been doing lots of LTP. They've been having sensory input, lots of learning. They're upregulating their AMPAs. This kind of makes sense. Whereas when you're asleep, you're not sort of experiencing things. Your neurons aren't as active, so they downregulate a bit. But the cool thing that he found then also was that when you stimulate those neurons in those postsynaptic plates to try and make them do more LTP, he used electrophysiology for this. He couldn't induce it in the ones who'd been awake for a long period of time. So they have all these AMPA receptors at the end plate, on the postsynaptic terminal, but you can't make any more LTP because basically it's saturated. So, and that can either kind of be electrically, or one theory is that it's like physically the space on the postsynaptic plate is just, there's none left. It's full of AMPAs. You can't add any more in, so you can't do any more learning. And this basically tells us that this balance between LTP and LTD is really necessary for our learning. and that sleep is really necessary for us to be able to keep taking in information and, doing our learning and memory. And that fits clinically with a lot of what we know about insomnia. Um, people who are sort of chronically sleep deprived are really bad at like verbal memory and learning words, learning new things. This all fits. This is just, it's one of my favorite studies. I have to put it in everywhere. There you go. And there's only for Migna and Georgia who've just joined. Since there's so few of you, if you just want to like say the answers, you can do the Slido if you want, but you can just say the answers also.
Is it GABA?
It is. You are correct. Okay. So GABA is the major inhibitory transmitter. We finished with glutamate. We're now doing the opposite. This is our inhibitory transmitter. Again, this is one of my revisable flashcard slides that you don't need to look at if it's not how your brain works. But again, things that we need to know are that it's synthesized from glutamate, so we need a balance of the two, and that when it's degraded, it can turn back into the TCA cycle, turn back into glutamate, all this recycling cool stuff. Our receptor types for GABA, we have two major ones. We've got GABA A and GABA B. GABA A are the fast-acting ionotropic receptors. They work by allowing chloride ions straight into the cell, which is going to hyperpolarize it. It's an inhibitory end plate potential, and that's going to make the cell less likely to fire, thus inhibitory neurotransmitter. GABA B is a slow-acting neurotransmitter, metabotropic, which acts in a kind of second messenger cascade, works by putting potassium out. Rather than bringing negative ions in, we put positive ions out. And the same thing happens, we hyperpolarize and we're less able to fire an action potential and we get inhibitory signaling. Another one. This is kind of a mean question because it's all clinical, but it's
So the
clinical.
indication is when would you not use this drug?
So an indication for a drug is something that the drug is used for. So what is not what are benzos not used for?
Would it be, this is mostly a guess, but would it be epilepsy?
It's not epilepsy. We're going to cover epilepsy right at the end, and I'll explain why.
Would it be insomnia?
It's also not insomnia. If, think about how GABA works. It may be that, you know,
If myasthenia gravis is a neuromuscular junction deficit,
it is.
then
It
it
is.
can't be a GABA related thing.
Yeah.
All right.
So the answer is myasthenia, because we know GABA is inhibitory. Even if we don't know what like the mechanisms of all of these pathologies, we know that GABA is an inhibitory signaler, right? And all of these above ones, epilepsy, anxiety, insomnia, agitation, they're all kind of hyperexcitability things. They're all sort of too much arousal things. So we wouldn't want to inhibit. Benzodiazepines act by increasing GABA. I'll cover that in a second, but we don't want to decrease inhibition in things where we're already too excited. So myasthenia is the only one really where that would make sense. That might be a bit of a mean question, sorry. So GABA is also really cool. They really, really like to ask you about benzodiazepines and GABA receptors. They're just like, I don't know, they can't get enough of it for some reason. So there's lots of information here. You don't need to know all of this at all. I put it lots on here because different people will pick and choose different things that they find memorable to stick in their essays or whatever, but you don't need to learn everything on here. The bits that you do need to know, you need to know about benzodiazepines. So the GABA receptor, GABA A receptor, it has allosteric binding sites on it, as well as the GABA binding sites got allosteric binding sites. And benzodiazepines work by they bind to the allosteric binding site and they potentiate the effect of GABA. So they allow GABA to work more by doing that. So you get more chloride into the cell, you get more inhibition. And benzodiazepines, I don't know if they've told you guys like what, how they work. They basically are like sedatives. So they make you very sleepy, they make you very it's like sedated. They are soporifics, so they do make you fall asleep. And they are used in anxiety quite a lot. So when people become very, very agitated, you can give them a benzodiazepine. they basically just chill you out, and that can be applied to many, many different hyperexcitable things, like the ones we covered on the other slide. Um, the other things here are just like fun little things that you can mention if you want. Good to know about Huntington's. That's a disease of the basal ganglia of the globus pallidus, where you lose your GABA neurons, so you lose your brakes basically. And Huntington's is characterized by these really big, jerky, involuntary movements and sort of dance-like movements, like called chorea. So you get a hyper mobility basically because you've lost your brakes, you've lost your inhibition. You need to know a little bit about glycine. It's not, not masses, just kind of it's there, it's inhibitory. It works more in the spinal cord than in the brain, but it is a little bit in both. Um, it says no about glycine and glycine receptors. The glycine receptors are the GlyRs. Those are fast-acting ionotropic receptors. They work in the same way as the GABA A receptors. So you get chloride coming into the cell. They also work as a coagonist for the NMDA receptor. So that's a bit interesting because they kind of contribute to excitatory transmission as well. But you don't need to know about that. It's just a fun little add-on. Um, Strychnine is cool. It's cool to know about. It basically blocks the um, glycine receptor, and then you get sort of chronic activation of your muscles, and you end up spastic and paralyzed. And they use it as a neurotoxin. So it's one of Agatha Christie's favorites. Everyone gets poisoned by strychnine. This is just a little diagram to show you the time course of the receptors we've spoken about. So AMPA and GABA A act very fast, like we've spoken about, they're ionotropic. NMDX a little bit slower because we spoke about the magnesium ion that's blocking it, that needs to be pulled out the way before the channel can open. And GABA B is much longer acting, takes much longer time to wear off, and that's because that's metabotropic, and we have to use all our second messengers, and it takes a little bit more time. Go.
That'd be ACH.
It is ACH, you are correct. So ACH, there is a lot to talk about with ACH. We are going to do a neatly packaged nutshell of ACH. They they specifically say they want you to know about choline acetyltransferase. All you need to know about that is that it's the thing that makes ACH, and that it's a drug target for some things. ACH, it works in a cycle. So inside the cell, it's created from acetyl-CoA and choline. They put it together with choline acetyltransferase. They make ACH into a vesicle. Vesicle releases onto the neuromuscular junction. The ACH activates its receptor. And then it's broken down by a very important enzyme in the synaptic cleft called acetylcholinesterase, which breaks it back into choline and acetate. Choline is taken back up into the cell, and the cycle repeats. So it keeps recycling. It's always going. Are types of ACH receptors. Broadly, we have nicotinic, which are the fast-acting ionotropic ones. Those are the ones we use at the neuromuscular junction, which you covered in first year in horrifying detail. It's excitatory. Well, it's going to depolarize the cell. It's going to make it more likely to fire. Action potential goes into the muscle cell. That's how you get muscular contraction. That's what we see over here. And then the muscarinic receptors are more of the kind of visceral parasympathetic functions. So that's stuff like your dry eyes, your dry mouth, sweating, all of those things. Good to know about that because there are lots of anti-muscarinic drugs that we use for various things, and they produce side effects that can affect these things. We'll cover that in a little bit more detail here, in fact. So this slide and the next slide, I find it really hard to learn just like straight up fact about science and molecules. It's not how my brain works. I think it's much easier to remember things when you have a point of reference, and clinical stuff, uses things that are kind of practical. That works for me. So this slide and the next slide, if you can understand them, you've basically grasped ACH. You don't need my horrible flashcard slide at all. So myasthenia, we spoke about a little bit. It is a condition where you have an autoimmune attack on your postsynaptic terminal, specifically on the neuromuscular junction postsynaptic terminal. So that can come from either antibodies to the nicotinic acetylcholine receptor or antibodies to muscle-specific kinase. There are some people who are seronegative, which is a bit weird, but basically, these antibodies you create, they block the nicotinic acetylcholine receptors, and all the ACH that's released into the synaptic cleft does nothing. So you go and try and contract your muscle, it just doesn't work because you can't get that action potential into your muscle. So it then kind of follows that your symptoms, they get muscle weakness. This particularly comes about in the sort of ocular muscles, the bulbar muscles, so that's like of the throat, breathing, swallowing, respiratory muscles, and limb muscles as well, particularly proximal ones. That, as you can imagine, can be very, very dangerous. If your swallowing muscles and your throat muscles stop working, you're going to choke. If your respiratory muscles stop working, you stop breathing. It's very bad. It can be very bad, myasthenia. Um, something that you can use to tell it apart is what we call fatigability, which is the more you use your muscles, the harder it gets to use them, the more tired they get. And that's because you're using up your acetylcholine. The receptors that you can use, are then becoming like you're using up your acetylcholine. You haven't got enough to activate the receptors you do have. So the more you use your muscles, the weaker you become. So people with myasthenia will often present, they say like, oh, my eyes get really droopy in the evenings, but they're fine in the mornings. It's because you've been using them during the day. And we manage it with something called pyridostigmine, which is an acetylcholinesterase inhibitor. So, like I said, when we use the muscles too much, we use up the ACH. If we block the thing that breaks down the ACH, we end up with more ACH in the synaptic cleft. There's more about to activate your receptors, and you're more able to do your movements and activate your muscles. That if you can understand that, then you understand acetylcholine metabolism, basically. Other things that are useful to know. Alzheimer's. There is a cholinergic hypothesis of Alzheimer's, which is that we lose the cholinergic neurons in the brain, and that's what causes you to lose your memory. So, if we know that myasthenia is a disease of acetylcholine and it affects your movement, we know that acetylcholine does movement. If we know that Alzheimer's is a disease of acetylcholine and it affects your memory, we know that acetylcholine does memory. They've found some people who did a study found that they looked at levels of choline acetyltransferase, the enzyme that we use to make the acetylcholine, in Alzheimer's patients after their death. The brains of people with Alzheimer's after their death looks a bit like this. They are just shriveled. There's a lot of brain loss because we have a lot of acetylcholine neurons. They just die and the brain shrinks. With reduced choline acetyltransferase, that's what these black dots are. Those are levels of choline acetyltransferase in people with Alzheimer's. They're much lower at death. So then it follows that if you don't have the enzyme to make your acetylcholine, you haven't got enough acetylcholine, you lose memory. We manage it also with acetylcholinesterase inhibitors for similar reasons as myasthenia. There's limited evidence. They do a certain amount, they don't do a certain amount, but we haven't really got anything better at the minute. But a lot of people don't want to take them because they can give you some really nasty gastro side effects. And again, if we know that, then we know that acetylcholine works in your viscera. It all kind of follows. Lastly, Parkinson's disease. We manage Parkinson's with muscarinic antagonists quite a lot because acetylcholine does movement, like we spoke about. But it also you get all these parasympathetic symptoms with Parkinson's that can be really quite distressing for people. So like your tremors, come from that in a certain way, and people get excessive drooling and stuff, and it can really affect how much people want to go out, how they want to live their lives. So if we can make that a bit better for them, then it really improves quality of life, and we can do that by blocking that parasympathetic system that causes you to drool and things like this. With stuff like glycopyrronium, which I think you cover in first year. But side effects of blocking your muscarinic receptors are you have like dry mouth, dry eyes, you get nauseous. Some people get confused, so it's kind of you want to use this like early on in the Parkinson's progression. But that's basically just an example of all the parasympathetic stuff that acetylcholine does. And if you can get these diseases, how they work, how we treat them, you can understand acetylcholine. That's as hard as it gets. So monoamines, there are 3 that they want you to cover. Lots to talk about with monoamines. This is a general flashcardy slide about general monoamines. It's all fairly self-explanatory. I'll cover some of it about the specific ones in more detail. Um, One interesting thing is the way that they're released. They're not released from a presynaptic terminal onto a postsynaptic terminal in the way that other cells are. They're kind of from these like swellings in the axon, which are called en passant varicosities, which means they can act on many, many different postsynaptic neurons at once. Let's start with dopamine.
It's pars compacta, I think.
It is pars compacta, you are right. That is a mean question. Um, and that will become relevant in Parkinson's. We'll speak about that. So dopamine comes from the pars compacta. It also comes from a couple of other areas. VTA is like, it's quite similar. It's all midbrain stuff. Monoamines mostly come from the midbrain. There's this weird hypothalamic origin of dopamine, which you don't need to know masses about, other than that site is what will cause your hyperprolactinemia when you get too much dopamine. So some people, I'll talk about it in a second, so I'll confuse you. But so yeah, dopamine is made from something called tyramine, which is synthesized into what we call L-DOPA. You may have heard about this as a Parkinson's drug. It's a dopamine precursor, and then we make dopamine from that. Two types of receptors, D1 and D2. They're both metabotropic. Almost all monoamine receptors are metabotropic, apart from 5-HT3. That's the only one. Basically, everything else is slow. It's metabolized by monoamine oxidases. These will be relevant for when we're thinking about drug actions. Also, this thing called COMT, which you don't really need to know about. And the reuptake transporters that we've spoken about are also very important drug targets. The dopamine one is called the DAT. All of these pathways, these horribly named pathways, I've put a bit about them in the notes. So if you do the feedback form at the end, you can get those notes. But basically, things that dopamine is important for is movement, reward, and cognition. It's people talk about it as like the happy hormone. That comes from the kind of idea of it as a reward neurotransmitter. It encodes reward in the sense that we learn to do things that we like. And clinical relevance, we've got Parkinson's and we've got schizophrenia. Those are the main ones. So let me see my next. Oh wait, I'll come back. So Parkinson's, the way it works is you lose your dopamine neurons in the nigrostriatal pathway. Basically, you lose your midbrain dopamine producing neurons. You end up with too little dopamine. We know that dopamine does movement. So Parkinson's patients will have what we call bradykinesia, where they move very slowly. Their movements have very slow, like very small amplitude. So if I can do this, Parkinson's patient could only maybe do that because they don't have enough dopamine to do the movements that they want to do. And we can treat Parkinson's by either we give them L-DOPA, we just give them more dopamine, which acts as an agonist. We're just, stimulating more of our receptors. Or we can give them monoamine oxidase inhibitors, which very similar to how acetylcholinesterase inhibitors work. We just stop the breakdown of dopamine. We end up with more signaling. We end up with more movement. It can really change people's lives. Schizophrenia and mania. We don't really understand schizophrenia very well, but one of the things we think about it is that it's caused by too much dopamine. And we think this because all of our schizophrenia drugs basically they work by antagonizing dopamine receptors. And that seems to make people less psychotic. So Davis and Kahn came up with that idea. And we have loads and loads of different antipsychotics. Different types, we've got typical and atypical, just that basically refers to which receptors they act on. But if we reduce the dopamine signaling, then people tend to not have as many hallucinations, not have as many delusions. Basically, we're reducing excitability. A similar way we're reducing excitability and reducing hyperarousal. And then interestingly, cocaine it blocks the dopamine reuptake inhibitor. So you take cocaine, you have more dopamine signaling, you do more reward, you get happier. This, if she'll work, which I hope she will. Do you guys know what this is? That's my next Slido question. It's a spoiler, but just think about what might be happening.
I mean, is this the testing for bradykinesia, like seeing the magnitude of the movements that can be made?
That one, that example with that lady, you're absolutely right. That's what they were asking her to do. Let's see if I can rewind the video once you've seen this. You're absolutely right. That's what they're asking her to do. But what we're actually looking at is her tongue here. So the movements
Oh,
she's
okay.
doing is a task she's been given, but her tongue is moving without her control.
Okay.
Do you guys know what you're looking at there?
Would it be ticks?
It's not ticks. Ticks are sort of short and sharp. So you might get a kind of something like that. Those people are they're sort of more repetitive, slower movements. They're lower amplitude than ticks.
Is it the tardive dyskinesia?
It is tardive dyskinesia, yeah. Um, these other things, Parkinsonism is when you get slowing of your movements and um, like you said, the smaller amplitude thing. So that lady who was struggling to do that, she's also showing some signs of Parkinsonism. But that was a task that they were asking her to do. We were looking at her mouth, really. I should have said that, sorry. Um, Tremor is more repetitive. Tremor is sort of you'll sit there and do this. I don't know if you saw the guy at the end with the legs, but it's more kind of like a writhing movement, less kind of, cyclic than a tremor. And dystonia is about tone. So that's you get involuntary muscle tone, which means you basically contract and you stay there. So something called like torticollis, you might get stuck like this with your head turned. It's not a sort of it's not a movement. It's more a kind of stiffness, for want of a better word. So, there you go. And I'll talk about type dyskinesia in a bit. Oh, wait, no, that's the last question. Sorry. Here we go. Have you guys covered this?
I don't think so.
Okay. It
I
is,
mean,
it's in your syllabus. It's like a kind of small print point, but it is in your syllabus. It's okay.
I'm thinking basically that the tardive dyskinesia, what it looks like is it looks like a disinhibition, that the voluntary movement is being accompanied by an involuntary movement as a result of like a failure of inhibition. So
Okay.
it's probably not going to be benzodiazepines or barbiturates because they upregulate your inhibitive neurons.
Yeah, you're spot on with that logic. Yeah.
But
Um,
I'm not sure how I would just pick apart the other three here.
okay. So,
Maybe
Mechanism of barbiturates.
sorry.
It's the mechanism of barbiturates.
Barbiturates, they work on the GABA receptor as well. They're a bit like benzodiazepines.
Right.
This one is basically something you just kind of have to know. Um, you're absolutely right about we've got excessive movement and involuntary movement. So, barbiturates and benzodiazepines as sedatives, we can rule them out. Um, Anticonvulsants, we will cover at the end. But they are basically they want they're to stop you having epileptic fits. So they're also going to be a bit um, they're going to be inhibitory as well. They're going to stop your movement and stop your over excitation. So it's not going to be that. SSRI,
SSRIs stand out as the only class of drug here that is not inhibitory, that is like going to have an excitatory effect on the nervous system as a whole.
yes, your logic is good. Your logic is good. Unfortunately, that is not how it works.
Okay.
There is a weird paradox here. SSRIs, we use them for depression. They don't really affect your movement in that kind of way. They have side effects, but more kind of GI stuff. They don't affect your movement. The answer is antipsychotics oh, well, nice one, Lara. Um, so tardive dyskinesia is, if you think about the words, tardive means delayed or late, and dyskinesia is the dys means involuntary, kinesia comes from like kinetics is movement. So you get involuntary late onset involuntary movement. Um, they come it happens when you use dopamine antagonists for a long time. That's a fact you just kind of maybe have to know. Um, it's a weird theory where if we block the dopamine receptors in the brain, we think that the brain trying to be super helpful is like, oh, I'm not getting enough dopamine, I'll make you more receptors. Then you get more receptors, the receptors you have become more sensitive, and you get this kind of hypersensitivity to dopamine, so that when you do release the dopamine, you end up with too much movement. And that's where you get these kind of involuntary, like the facial twitching, all of these symptoms here. Symptoms of tardive dyskinesia tend to be face, mouth, eyes, and kind of limb, not sorry, not limbs, kind of trunk area. So you can people kind of will like ride in their seat sometimes. Um, it's it's quite common in people with psychosis. Lots of the antipsychotic drugs will affect your movement in some ways, and that's because dopamine does your movement. Like in Parkinson's, it makes sense. I see what you mean about if we block the dopamine, you expect to have little movement. You do also get that as well. You can get some Parkinsonism, um, but it's just this weird kind of process. It's a very small print in your syllabus, but it's probably just something to rote learn. We'll move on from dopamine. Dopamine's done.
Is it the locus coeruleus?
It is the locus coeruleus, yeah. So flashcards for noradrenaline is from the locus coeruleus. The synthesis, it's the same pathway as dopamine, it's just one step down. So tyramine, you make L-dopa, you make dopamine, and then you make noradrenaline off dopamine. It's exactly the same. Types of receptors, we've got alpha and beta. And each of those, we've got two main subtypes. Those are found in your brain, but also in your periphery. And many, many, many different drugs act on those. So they all have like lots of weird side effects. We'll cover some of the main ones. I'm going to focus it on the brain. There's lots of peripheral noradrenaline actions, but I'm going to focus this on the brain stuff. Metabolism is also monoamine oxidases. Monoamine oxidases break down monoamines. The clue is in the name. So if you target monoamine oxidases with drugs, you will affect your monoamines. That's basically generic to all of the monoamines. The same one like called COMT before, and then I should say NET. It's a NET because Americans spell it with an E. And that's your reuptake that we block in some conditions as well. Again, noradrenaline is sort of an excitatory neurotransmitter. It does things like arousal, and it so things it says sleep wake cycle. Basically, it is in charge of keeping you awake, and with arousal comes things like anxiety. If you're too aroused, you get anxious, you get nervous, and your mood can go down as if with hyperanxiety, your mood's sorry. With high noradrenaline, you get anxious. With low noradrenaline, you get depressed. It's kind of two ends of the spectrum. Clinical stuff, like we spoke about the anxiety, it's because noradrenaline acts on the amygdala, so you get more kind of fear stimulation. If we block the noradrenaline with beta blockers, like propranolol, then that helps people's anxiety because you're less fearful and you're less aroused, like mentally aroused. In depression theories of depression are very, very complex. Nobody can really agree, but one of the theories is monoamine theory, which is that you don't have enough monoamines. That's why your mood is low. So if we give people things that increase our amount of monoamines, so things like venlafaxine, which is a serotonin and noradrenaline reuptake inhibitor, we increase the amount of noradrenaline in the synaptic cleft, we get more noradrenaline signaling, we become less depressed. That's a very simplified way of thinking about it, but you don't need to know anything else. And then interestingly, I actually didn't know this. ADHD is obviously a disorder of attention. You don't have enough attention. If we inhibit the noradrenaline reuptake with amphetamines, then people seem to be able to focus better. It seems counterintuitive to give people with ADHD stimulants since they're already sort of like hyper aroused, but because that hyper arousal interferes with your attention, that's how we think that works. Last one, I mean.
The RAF nuclei.
That's it, yeah, raphe I don't know why they care so much about knowing where they come from, but it's like a specific point. So serotonin we hear about all the time. It's from the dorsal raphe nuclei. This one's made from a different precursor, so it's tryptophan rather than tyramine, broken down to 5-HTP and then 5-HT, which is just the other name for serotonin. Um, there are loads of serotonin receptors, loads of different numbers. You don't need to know the subtypes at all. Most of them are metabotropic. As I said before, 5-HT3 is ionotropic. I'm not. I don't think you really need to know what that means, but like, as in the consequences of that. But it's just an odd little thing. Monoamines, once again, breakdown. Monoamine oxidase is breakdown monoamines. And the serotonin reuptake inhibitor, the serotonin reuptake transporter is called the SERT. That's very important in depression. That's something that is targeted by a lot of antidepressant drugs. Similar functions to noradrenaline. So we're promoting wakefulness. We're looking at like high serotonin makes you gives you anxiety for similar reasons. Lower serotonin we think maybe has something to do with low mood. It's also important in your cognition. This we can see in people with depression often have cognitive symptoms. They often struggle with things like brain fog and concentrating and attention due to low serotonin. Well, it could be due to low serotonin. There's also serotonin acts on the gut. This is a good one to know for sort of side effect things because high serotonin can cause you to be like nauseous, vomiting, changes in your bowel habits, that kind of thing. Because when we give people drugs to increase their serotonin in their brain, it also acts on their gut. Depression, the thing that we know, the biggest sort of clinical relevance of serotonin, I would say, in my humble opinion, is depression, coming from the same monoamine theory as noradrenaline. SSRIs are used all the time. So many people are on SSRIs. That's the serotonin selective serotonin reuptake inhibitor. So we block the SERT, the serotonin stays in the synaptic cleft. We get more serotonin signaling. After a while, people become less depressed and the mood improves. We can also use them to treat people who have have nausea and vomiting. So in a lot of like chemo patients, you'll give them things like ondansetron, and that blocks the 5-HT3 receptor and just chills out your bowels a little bit. Again, you don't need to know these things in detail. I just find them helpful if you know what clinical stuff is related to the neurotransmitter and what we do to it, then you can kind of intuit what the transmitter does. And lastly, migraine is just a bit interesting. We think it's caused by vasoconstriction of the vessels in your brain, but we use serotonin agonists called triptans quite a lot to prevent people's migraines. Not 100% sure how that works, but it's just another use. This is one big horrible table that summarizes everything in the past 3 slides. Again, you don't need to like memorize this if this isn't how your brain works, but I like having everything in one place. And the blue stuff is the stuff that you don't actually need to know. That's all of monoamines in one place. So finally, a little bit on epilepsy. We haven't got that much on epilepsy. So a seizure is defined as uncontrolled electrical activity between neurons in your brain. Epilepsy is a disease. So seizures are a symptom. Epilepsy is a disease. Where you have to have had 2 or more unprovoked seizures more than 24 hours apart. We say unprovoked because seizures can be caused by all sorts of things, like infection, like trauma, like mass lesions in the brain. So they have to be, we don't know why this has happened. It's come out of nowhere. What seizures look like, you can get problems with your tone, like we spoke about with the drugs on the slide here before. Abnormalities in tone, either you get very stiff or you get very limp. Abnormalities in movement, people will like twitch, writhe. That's the kind of tonic-clonic thing you think of when you think of seizures. But you also get all sorts of other weird seizures. Seizures can start from aberrant electrical activity anywhere in your brain. So depending on where they start, they'll look like different things. So you can also get lots of like very kind of strange seizure symptoms, like randomly staring into space, laughing, crying. People talk about funny sensations they have. Some people know when an epileptic seizure is going to come on because they get funny feelings in their body. And then they can also change your awareness. So absences are like people will just kind of blank out and sort of stare into space, and you won't be able to get through to them. They're not unconscious, they're awake, but they just aren't taking anything in at all. Um, and also some people will completely lose consciousness, collapse on the floor, that kind of thing. Risk factors for epilepsy. Um, there's a lot of them. Also, these are risk factors for seizures. So loads and loads of different things can cause you to have seizures. Um, it's basically very non-specific. You can get them at any age. If you've got a family history of epilepsy, it makes it more likely, but trauma, strokes, dementia, because we're sort of changing the brain architecture, infections, all of these things can cause you to have seizures, and it's much more common in um, low socioeconomic backgrounds. So there's all this like biopsychosocial stuff. We don't understand it very well at all. Um, very basic pathophysiology, which you don't need to know, is that it's a pathology of synchronization of the cells in your brain. So you get this aberrant signaling coming from one spot. It then spreads to a certain area. In some people, it spreads to the whole brain. Um, and that causes you to behave in those different ways that we spoke about. One of the major theories of epilepsy is that it's caused by an imbalance between your GABA and your glutamate. And that ultimately falls on the side of too much glutamate signaling, not enough GABA signaling, hyperexcitability, sort of brain shocks, electric shocks in your brain functionally. If we know about this, then we can think about the drugs that we use to treat it. So basically, we want to decrease the excitability of the neurons in the brain to treat the seizures. To diagnose it, the gold standard is an EEG. That's what this lady is having, where you put all these electrodes on the brain, you measure the brain waves, and you see if they're synchronized in ways that you don't expect them to be. It's all very complex. This woman looks really happy to be there, which I don't think most people are, but the idea is that you want to try and catch an epileptic seizure on the EEG. So sometimes people will stay in hospital with the electrodes on their head, and they'll just sit there and wait for them to have a seizure to diagnose it as epilepsy, because you can get seizures that aren't epileptic. But also, it's really important to scan the brain, because, like we said before, there are all sorts of things that can cause you to have a seizure, or multiple seizures if the thing isn't resolved, that aren't true epilepsy. So strokes, tumors, you want to rule that out before you diagnose someone with like idiopathic epilepsy. This might be your last Slido.
Would it be the potentiation of GABA?
Yeah, you're absolutely right. For reasons of, we want to reduce the hyperexcitability like we spoke about. So you can manage epilepsy in a few different ways. The vast majority of it is managed with drugs. And of those, there are two main mechanisms. So either we can increase the GABA, so things like benzodiazepines, like we spoke about, can be used in epilepsy, barbiturates, and then other things that sort of modulate your GABA activity. So GABA transaminase is the enzyme that breaks down GABA. If we block that, we get more GABA, we get more inhibition, and we can block the GABA uptake inhibitor as well. But yeah, it's mostly these sort of top two. We don't really use barbiturates that much anymore because they have like quite bad side effects. But benzodiazepines are used all the time in epilepsy. Or we can decrease the glutamate signaling, and we do that kind of in an indirect way by blocking sodium, voltage gated sodium channels. That's not meant to be a C, that's meant to be an Na, sorry. So if we block the sodium channels, then we don't get the glutamate release. We reduce the excitability of the brain, and we are able to sort of control those hyperexcitable seizures. Things that we use for that are the main sort of long-term epilepsy drugs. So that's like phenytoin, carbamazepine, and lamotrigine. When people are acutely having a seizure, like they're in the middle of the seizure, if it goes on for more than 2 minutes, or it's different times for in hospital and outside, but if it goes on for long enough, you want to give them something to stop them having a seizure, because the more you seize, the more damage it does to your brain. When someone's actively having a seizure for a long period of time, we call that a status epilepticus. And we treat that by, we give them the benzodiazepine, either in the mouth or per rectum, and we give them phenytoin. So that's basically to like stop them imminently seizing. We increase the GABA and we decrease the glutamate, just to try and like bring the body back to a sort of neutral state. Once that's done, we want to give them something to stop them having another seizure in the future. And the things we use for that are things like valproate, carbamazepine, lamotrigine. So that's more of the sort of decreasing the glutamate signaling than the GABA stuff. Um, Valproate is interesting because you don't want to give it to women who could become pregnant. It is very teratogenic, which means it can cause birth defects. So you don't want to give that to women who may become pregnant. Also, because even if they're not planning to, you don't want to put them on a drug and then have to take them off again. Also, interesting new evidence now that it is also causing fertility problems and birth defects when you give it to men. So we're a little bit hesitant about using valproate, but a lot of people are on it with no problems, and it can completely change people's lives. The other things we can do for epilepsy, we can do surgery if people are not responding to drugs. It's important that we treat seizures because, as I said before, the more you seize, the more damage it does to your brain, and you can end up with things like, memory loss and all of this stuff. The major ways that we can do neurosurgery for epilepsy, you can either reset, if you can work out where in the brain the seizure is starting from, the point in the brain where the aberrant signal is coming from, you can lock that bit out. It's usually temporal lobe. And you can basically just, yeah, cut a small chunk of the brain out, and then you don't propagate the signals because they're not coming. Or if you can't work out where it's coming from, people are having very generalized sort of whole brain involvement seizures. You can disconnect different bits of the brain from each other. So, for example, if you cut the corpus callosum and you have a seizure that starts in one half of your brain, it can't get to the other side. It cannot propagate to the other half of the other hemisphere. So you don't end up having a whole generalized whole brain seizure because it's sort of restricted to that half of the brain. These aren't done so much, but we do resections in Oxford actually. Um, yeah, it's it's cool stuff. And that is it. That is all of synapses and epilepsy. I'm sorry, that was like a lot of information all in one go. It's quite a big topic. But just learn what you have to learn. Um, find ways that you can remember it. The clinical stuff works for me the best, but yeah, find what works for you and you'll be fine. You'll be so